Hi, good morning, everybody. I am Malinda West from the University of Wisconsin. I am moderator for today's poster spotlight session. I would like to welcome you all to poster spotlight session 4, Gaps in Timing, Treatment Selection, and Supportive Services for Cancer Care. There will be time for questions after the 4 panelists and then discussants speak. Our first presentation is the clinical impact of timing of systemic therapy in patients with early triple-negative breast cancer, presented by Dr. Stephan Seitz, Department of Gynecology and Obstetrics at University Medical Center, Regensburg, Germany.
So thank you for your introduction. We get the slides. They're up? Here we go. Okay, sorry. Okay. On behalf of the study group, I want to thank the committee for choosing our abstract to present our work. The first author, Dr. Hatzipanagiotou, had to step back as a presenter to avoid the uncomfortness of the long travel in her pregnancy. So I have the pleasure to present the work. And here are our conflicts. For this study, we have no funding to declare, so this is of academic interest only. This study aims to clarify whether timing of systemic therapy has an impact on survival in patients with early triple-negative breast cancer based on real-world data. In the literature exists conflicting data, not evaluating by histological subtypes or data based on clinical trials, not reflecting the real-world population and practice. We evaluated the interval from triple-negative breast cancer pathologic diagnosis to the date of first administration of neoadjuvant chemotherapy, or interval from the last surgery to the date of first administration of adjuvant chemotherapy. Data were collected based on a large population-based regional clinical cancer registry. The catchment area encompasses a population of more than 2.2 million people, including Upper Palatina and Lower Bavaria in Germany. Regular updates were conducted for patients' vital status information and active hospital follow-ups through linkage with state and national health offices and queries to residence registration offices. Included were women with a diagnosis of triple-negative breast cancer between January 1st, 2010 to December 31st, 2018. Information about diagnosis, treatment, course of disease, histological parameters, long-term follow-up, local, regional, or distant recurrence, and mortality were collected. Parameters like TNM stage, grading, Ki-67, date of diagnosis of the primary tumor, age, last date of follow-up, date of recurrence, date of death, Charlson's comorbidity index, date of first application of chemotherapy, date of last surgery were included in the evaluation and multivariate analysis. Follow-up calculated using reverse Kaplan-Meier method log-rank tests for comparison of subgroups, hazard ratio, and p-values and confidence intervals were calculated for each model. The results show a median follow-up of 3.5 years. 270 patients were eligible for the neoadjuvant group. One can see a clear spread of curves over time with a trend for better survival if the therapy was administered within the first 42 days. This becomes significant after 56 days, with a backward stepwise selection showing a significant hazard ratio of 4.675 with a p-value of 0.043. For the cohort of adjuvant treatment, 245 patients were eligible. We found in a backward stepwise selection not significant hazard ratio of 3.434 with a p-value of 0.085. From our data, we conclude that there are critical time intervals for initiation of systemic therapy in patients with early triple-negative breast cancer. With reduced overall survival in neoadjuvant therapy when neoadjuvant therapy is applied later than 42 days after diagnosis, or if adjuvant chemotherapy is applied later than 42 days after surgery. We recommend not to exceed the 6-week interval until the initiation of systemic therapy in patients with early triple-negative breast cancer. For more information and deeper look into the data, I want to refer to the publication about the neoadjuvant cohort shown here on the right lower corner, which was published during the year after submission of this abstract and the upcoming publication accepted in Breast Cancer Research and Treatments a few days ago for the adjuvant subgroup. Thank you very much.
Thank you. Presenter 2 is Dr. Siddhartha Yadav from the Mayo Clinic in Rochester, presenting a poster on BRCA testing and PARP inhibitor utilization in real-world HER2-negative metastatic breast cancer.
Thank you for this opportunity. My disclosures are listed here. So the NCCN guidelines recommend that all patients with HER2-negative metastatic breast cancer undergo germline genetic testing or be offered testing. However, there is limited data in terms of the real-world outcomes on germline genetic testing and utilization of PARP inhibitors. So this is a retrospective cohort study using real-world data from US Flatiron Electronic Health Record Database. We included patients over the age of 18 years between the dates of January 1, 2014 and July 31, 2022. And the primary objective of this study was to look at the rates of germline BRCA testing and PARP inhibitor utilization. An exploratory outcome was to evaluate overall survival by the use of PARP inhibitors. So the graph here on the right demonstrates the rates of germline genetic testing, BRCA testing rates over time in patients with HER2-negative metastatic breast cancer. The top two lines represent rates of testing in metastatic triple-negative breast cancer, and they have further been broken down by whether the metastatic disease was a recurrence, as shown in the red line, or whether the metastatic disease was de novo, as shown in the purple line here. The bottom two lines demonstrate rates of testing in metastatic hormone receptor-positive HER2-negative breast cancer, and again, further broken down by whether the metastatic disease was recurrence, as shown in dark blue line, and whether the metastatic disease was de novo, as shown in light blue line. So it's clear that between 2014 and 2022, there has been an increase in the rates of germline BRCA testing, and the rates appear to have been sharply going up since the approval of PARP inhibitor in 2018. However, when you look at even in 2022, less than 2/3 of patients with metastatic triple-negative breast cancer and less than half of patients with hormone receptor-positive HER2-negative metastatic breast cancer undergo testing. In terms of the results of the germline genetic testing, as expected, there was a higher rate of germline BRCA mutations among patients with metastatic triple-negative breast cancer, 11.1%, compared to those with hormone receptor-positive HER2-negative metastatic breast cancer, 6.2%. However, if you look at the data from a different angle, approximately 2/3 of all patients with germline BRCA mutation had hormone receptor-positive HER2-negative metastatic breast cancer. In terms of the overall survival with PARP inhibitor treatment for germline BRCA mutation carriers, one important point to mention is that the utilization of PARP inhibitor was lower among patients with hormone receptor-positive HER2-negative breast cancer, so 41.5% compared to 53% in metastatic triple-negative breast cancer. In terms of the overall survival, there was a numerically longer overall survival among patients among germline BRCA mutation carriers who received PARP inhibitors, 32 months compared to 21 months among those who did not. However, this data needs to be interpreted with caution because there were several caveats relevant to this analysis. In conclusion, the rates of germline BRCA testing is still low among patients with HER2-negative metastatic breast cancer and lower among patients who have hormone receptor-positive HER2-negative breast cancer. The same is true for PARP inhibitor utilization among patients who test positive for germline BRCA mutations. And we need further studies to understand why these rates of testing are low and what can be done to improve the rates of testing and utilization of PARP inhibitors. Thank you.
Thank you very much. The next poster, titled The Survival Benefit of Regional Nodal Irradiation in Clinically Node-Positive Breast Cancer Following Neoadjuvant Chemotherapy and Breast-Conserving Surgery, will be presented by Dr. Mahtab Vasigh from Department of Surgical Oncology at the Fox Chase Cancer Center. Thank you.
Yeah.
How did you get your slides up?
It was it.
They were there? Okay.
Somebody.
Is there some support from the IT to get the slides pulled up?
I can get my flash if they need it.
Oh, here we go.
Okay.
Excellent, thank you.
In recent years, thank you for having me. I have nothing to disclose. In recent years, there has been an increased use of neoadjuvant chemotherapy and pathologic complete response. Although encouraging, this leads to uncertainties regarding traditional auxiliary management. In current practice, clinically node-positive patients who receive neoadjuvant chemotherapy and undergo breast-conserving surgery, if become YPN0, may avoid an auxiliary lymph node dissection. However, regional nodal irradiation is still recommended in that group of patients. Those who remain YPN positive after neoadjuvant chemotherapy undergo a complete axillary lymph node dissection and regional nodal irradiation. In this study, we reviewed clinically node-positive breast cancer patients who received neoadjuvant chemotherapy and breast-conserving surgery in National Cancer Database between 2010 and 2020. Overall survival from the time of surgery were compared between those who did and did not receive regional nodal irradiation. This cohort included 8,270 patients. 35% of the patients became pathologically node negative. They had complete pathologic response in their axilla. 59% of the patients received regional nodal irradiation, and the median follow-up was around 5.5 years. The mean number of removed nodes was 10.4 and 9.6 amongst those who received and did not receive regional radiation. And the mean number of positive nodes was 2.4 and 1.9 amongst those who received and did not receive regional irradiation. In the final analysis, we could see that patients who became pathologically node negative had improved overall survival compared to those who still have residual nodal disease. However, the addition of auxiliary irradiation did not improve overall survival. We did a sensitivity analysis based on the final nodal status. Again, in either groups, YPN0 and YPN positive, the addition of regional irradiation did not improve overall survival. In conclusion, in patients who are clinically node positive, although some prognostic factors may bias practitioners into giving adjuvant regional radiation, it does not show an improvement in overall survival. Even in patients who remain YPN positive after neoadjuvant chemotherapy, despite higher number of removed nodes, again, the addition of regional nodal irradiation does not improve overall survival. However, we know that we need further studies to evaluate the role of regional nodal irradiation and its impact on local control and long-term survival in the future in order to create new guidelines surrounding the indications of regional radiation in the subgroup of patients based on initial burden of disease in the axilla and final response to neoadjuvant chemotherapy. Thank you.
Thank you. The next presentation, Dr. Sze Yi will be presenting a poster on the adverse effects reported via patient-reported outcome measures, a longitudinal analysis of the import high breast radiotherapy trial.
Good morning, everyone. First of all, I'm a PhD student from Institute of Cancer Research. And today, I would like to present you the results of a patient-reported outcome measure substudy from import high radiotherapy trial. I have no financial relationships to disclose. Patients receiving radiotherapy can experience both early and late normal tissue effects, which here we call them adverse effects or AEs. By early identification of patients with higher risk of reporting AEs, we can help facilitate more targeted support. Here we use data from IMPORT-High, a UK phase 3 randomized controlled trial which tested simultaneous integrated boost radiotherapy against sequential boost radiotherapy. The objective of this project is to investigate the trend and predictors of patient-reported adverse effects. 1,078 IMPORT-High patients were recruited into our sub-study. Patients reported questionnaires at baseline, 6 months, 1, 3, and 5 years, and 24 adverse effects that were most likely to be related with radiotherapy were included in this sub-study. You can find the detailed statistical methods and modeling in my poster, and I'll go directly to the key results. As shown in the top right corner in this figure, we can see that the number of moderate or marked adverse effects reported per person reduced over time after 6 months. I also looked into the individual time trend for different adverse effects and identified 4 different patterns, which are shown below in the bottom half of the slide. Starting from the left, we can see that trend 1 shows the adverse effect that increased the frequency at 6 months and decreased subsequently. These may reflect early radiotherapy-induced changes, which usually settle by 1 year. For example, the top pink line shows whether participants had breast becoming harder or firmer to touch, which is likely to be a combination of both edema and fibrosis. Which is also reported here is breast pain, which is shown in orange line. Moving across the slide, we can see that trend 2 shows those adverse effects that increase the frequency continuously since baseline. These may reflect late radiotherapy-induced changes, which can continue to develop over many years. Here, the pink line, we can see that it shows the change of nipple position, and the gray line shows whether the breast becomes smaller. Trend 3 shows the adverse effect that continue to decrease since baseline. You can find here many questions related to concern about body image. For example, the top red line shows whether patients think they're less physically attractive. Trend 4 shows the adverse effect that increase the frequency at 6 months and stabilize subsequently. For example, the top gray line shows whether patients had overall breast appearance change, and the black line shows whether people have problem getting a bra to fit. For each adverse effect, people who reported that AE at baseline were more likely to report the same AE at a later time point. Measurable factors at baseline are associated with subsequent AE reporting as listed in the table on the right. For example, people who reported anxiety at baseline were more likely to report more breast symptoms, such as smaller breast, arm symptoms, such as difficulty to move arm, and also concern regarding body image. Other predictors that are associated with multiple adverse effects reporting in the future are baseline reported depression, surgical deficit, age, and employment status. In conclusion, the number of moderate or marked adverse effects reported per person decreased over time. Patient-reported outcome measures allow us to separate the adverse effects into groups with different time trends. And among all the baseline predictors we measured, baseline anxiety was the predominant predictive factor for subsequent AE reporting. I would like to thank you for your time, and thank you to all the patients participating in our study.
Thank you, Dr. Ni. Next, we will have our discussant, Dr. Schellhorn from Yale School of Medicine in New Haven.
Good morning. I'd like to thank the conference organizers for inviting me to discuss these 4 exciting abstracts pertaining to gaps in the timing, treatment selection, and supportive services for cancer care. I have no disclosures. And just as a reminder, here are the 4 abstracts that I'll be discussing this morning. These 4 abstracts are excellent examples of real-world data. We're all, as physicians and scientists, comfortable looking at controlled experimental data, which relies on a population of homogeneous patients with strict eligibility criteria and ultimately can determine the efficacy of a new intervention. It's also the standard approach for regulatory approval. However, real-world evidence relies on more heterogeneous populations that reflect real clinical practice and answer questions for which no clinical trial has been done or is ethical, as is in the case of the first abstract. Evaluate uptake of treatment innovations, which can help create guidelines and guide practice. It may give insight into the future results of pending clinical trials, as in the case of the third abstract, and can help us generate hypotheses for future clinical trials. I'll add that patient-reported outcomes which can often reflect health status better than clinician report, kind of bridges the gap between these two types of evidence. So jumping into our 4 abstracts. The first abstract looked at the timing of systemic therapy in triple-negative breast cancer and asks the question whether and to what degree delays in systemic therapy can affect the ultimate outcome in this population of high-risk disease. It looked at a total of 732 patients. Only about 500 received chemotherapy, 40.3% adjuvantly and 43.6% neoadjuvantly. And not surprisingly found that with increasing time to systemic therapy receipt, overall survival decreased. And using that 6 weeks point as a cutoff, found a 15% roughly difference between survival in those patients who were delayed versus not. Sorry, my slides are automatically advancing. And this is an important demonstration of the need to minimize delays to the receipt of systemic chemotherapy, especially in triple-negative breast cancer. Our second abstract looks at real-world practice of a newer innovation in the treatment of breast cancer. In this case, we were looking at the testing of germline mutations in people to find patients who may harbor a BRCA 1 or 2 mutation, and look at the uptake of use of PARP inhibitors in patients who meet criteria to receive one. And this was using a database from Flatiron. What we found, or what the authors found rather, was that genetic testing rates have increased over time, and there was a sharp uptick in genetic testing in 2018 at the time that olaparib was approved for patients in this setting. But interestingly, even in the most high-risk patients, only about 60% of patients underwent germline genetic testing as of 2022. Also interestingly, not all patients with germline BRCA mutations received a PARP inhibitor, which suggests that a highly effective, potentially highly effective treatment remains unused in this high-risk population. And although these numbers must be interpreted with caution, the overall survival was numerically longer in patients that received a PARP inhibitor. Certainly provocative data. And the third abstract, looking at regional nodal irradiation for lymph node involvement, helps us understand and perhaps predicts the results of NSABP-B51. For patients with clinical involvement of the lymph nodes, most patients undergo a sentinel lymph node biopsy, and if that biopsy shows no pathologic disease involvement, may be able to avoid an axillary dissection. However, even patients with clinically positive lymph nodes and pathologic complete response may go on to be recommended and receive regional nodal irradiation. And so the question becomes, does that provide a benefit in terms of the overall survival? And can we predict the long-term results of an immature clinical trial, at least as of today, using real-world data? The data that is presented is very provocative, looking at over 8,000 patients who underwent neoadjuvant chemotherapy. And not surprisingly, predictors of regional nodal radiation receipt include increasing tumor size, increasing nodal burden, tumor phenotype. And regardless of the pathologic response in the nodes, there did not seem to be a benefit to regional nodal irradiation. It's certainly provocative. We should keep in mind that these were not necessarily balanced data, and that these groups were not matched by patient and clinical characteristics. And finally, the longitudinal adverse events after breast radiotherapy abstract looked at the sub-study of patient-reported outcomes in the IMPORT-High clinical trial, which tested simultaneous integrated boost against sequential boost after breast-conserving surgery. They looked at over 1,000 patients who were enrolled in this sub-study, trended adverse events over time, and looked at predictors of adverse events. Not surprisingly, adverse events were quite common even at baseline, with 74% of patients reporting some sort of adverse event, but these numbers generally declined over time. And the authors point out 4 different trends of adverse events, which I very methodically sketched out here in this table, and assigned adverse events to each of these trends. And this is really important to help us educate and inform our patients going forward, help us plan interventions and support for patients as they're undergoing breast radiotherapy, and to help them understand what to expect. So finally, just in quick conclusion, these 4 real-world studies are really helpful in determining what's important in terms of ultimate outcomes. Improving outcomes requires eliminating barriers to care and minimizing delays. That's true for time to systemic therapy. That's true for germline BRCA testing and use of PARP inhibitors. It's also true in terms of financial toxicity, and we need to look at programs and plans to help improve insurance coverage, out-of-pocket cost, productivity decreases as patients that are all associated with cancer care. The real-world evidence in the third abstract suggests no benefit to regional nodal irradiation after pathologic complete response, and we're anxiously awaiting the results of the NSABP-B51 study, which I believe to be presented tomorrow. And finally, patient-reported outcome studies are critical to the understanding of adverse events and the future education of our patients. I'd like to thank the authors for sharing their slides with me, for presenting this excellent data, and for all of you, thank you for your attention.
Thank you, Dr. Schellhorn. Excellent discussant for these 4 great cases. The floor is open for anybody with questions on the microphones. And while those penned, there are a couple of questions that have come in through the online chat. The first one is for Dr. Vasigh, asking from Mohammed Inam, asking to please comment on the endpoint of the trial. Was local regional relapse or progression-free survival examined?
Since we use National Cancer Database, data about local recurrence is not available over there. So we just could evaluate the overall survival. But we know that regional nodal irradiation may have an impact on decreasing the local recurrence, but we could not evaluate that.
Were any of the receptor subtypes analyzed in this also?
Yes.
Okay.
We included patients between 2010 and 2020 because we wanted to have HER2. So we adjusted
Receptor subtypes analyzed in this?
Yes, all the data based on their phenotype, and also all the other patient and tumor characteristics, It is adjusted.
Excellent, thank you. Microphone behind you. While he comes up to the stage, I've got another question here. This one is asking for our first presenter, Dr. Seitz. In some parts of the world, the delay to starting treatment is more than 6 months on average. What is your opinion regarding this 6-week goal in this light?
Yeah, we know that is a challenge, and the most interesting data for us was that we start treatment in our region within 6 weeks by 86%. So that was interesting as well, because it's a real challenge in the neoadjuvant setting as well, because you have to account for staging with CT scans and bone scans, and probably have fertility preservation issues or something like that. So this is a real short time slot, and we know that in other regions of the world you have the problem with the travel to the next center, and that is a problem. Yes, I think so. Yeah.
Thank you. Microphone?
Rick Bleicher, Philadelphia. So nice talks. Regarding the triple negative timing study. So if I heard you correctly, you had said that you did not reach statistical significance in the neoadjuvant setting. There are prior studies showing that they've not been able to reach significance for the outcome of delays in the neoadjuvant setting. And in this case, you've got 2 million patients, if I understood correctly. So do you take from that really in the neoadjuvant setting there's something different about this, where delays are not quite as important as they are in the adjuvant?
That could be an issue, and in the neoadjuvant setting we reach significance after 56 days, and we therefore conclude a cutoff of 42 days because it was close to the significance, and we see the spread of the curves. yes, there is a discussion in every paper when you read that if neoadjuvant therapy diminishes this problem of time delaying, but from base of our data, we have in the adjuvant as well as in neoadjuvant setting this time issue, and because of the small patient population data for 270 and 245, we could not reach the significance in the adjuvant setting. In the neoadjuvant setting, we could reach the significance, yes.
And was that overall survival or disease-specific survival?
This was overall.
Thank you.
Thank you. Good questions. One of the questions coming in from the online chat, this is from Jose Reyes, another one targeted for you, asking, how and why did you choose for the 6 weeks as a marker of interest?
Pardon?
Why did you choose for the 42 days for the 6 weeks of interest?
Yes, we divided the times in weeks, so we make a group of the first 14 days, a patient who receives the therapy within 14 days, and then every week. So we have not a continuum, but we had groups, we built groups by weeks, so we came up with 42 days.
Thank you. One of my questions, Dr. E, is for you. And hi, and asking about, did you explore any of the targeted strategies that may be of benefit to helping with some of the patient population, some of the ways to help with the depression or anxiety, like targeted strategies to help with that patient population with this?
The question is whether I explore the strategy.
Yes, if you...
Yeah, so this is only the patient-reported outcome sub-study alongside with the main trial, so we haven't done that, and this is just to help us inform future hypothesis and future strategy. Yeah.
Okay.
You have a question.
Oh, thank you. Sorry. A microphone over here, please.
Oh, that's okay. Hi, thanks everybody for your talks. I am representing the Ellie Fund in Massachusetts, and we provide wraparound services, food, transportation, childcare, integrative therapies, anything to relieve a patient's stress during treatment. And we partner with our physicians and researchers and hospitals. And I'm wondering, in the context of these talks, do you have partnering organizations that you can rely on to address the issues that you're bringing up here today on time delays?
I can maybe try to answer that for all of us. I think the resources that are available for patients differ across the country and certainly across the world. I know I practice in Connecticut, and we have a number of philanthropic organizations that help us provide those resources for patients. We have exceptional social work support. But I'd turn to some of my international colleague to speak to what other resources are available to help minimize delays to care and to help support patients in times of stress, such as undergoing chemotherapy. Yes.
Yes. Okay. Yeah. So yes, I can only talk about Germany at least. So we have a national program for these breast cancer centers, we call it in Germany. And if you are certified as a breast cancer center, you have to have a network to include all these issues which I mentioned before. So you have clear partners where you get your bone scans, etc. And it's more or less centralized for the in particular regions. You have centers where you have to go if you get this diagnosis of breast cancer. And then I think this is the most important issue because then you get a clear therapeutic plan, and you don't have to go from door to door. So this is the therapy is carried out from one hand, and that's I think a very important issue.
Yes, thank you. Okay, thank you everybody. We're going to move on to the second half of the session where the next presenters will come. Okay, thank you, everybody. The next presentation is a poster by Dr. Aboumrad, presenting on from Johns Hopkins, presenting on the breast cancer recurrence among women with pre-diagnostic major depression and coexisting substance abuse disorder, a retrospective study in the United States VA Health Administration cohort.
Hi, good morning. I'm actually a PhD student in the department, and I'm mentored by Dr. Kala Visvanathan. And I have no financial relationships to disclose. So before getting into this, I want to provide a little context. We were able to present a prior study on major depression at this conference last year, and the findings of that study showed that women with major depression have a significantly higher risk of breast cancer recurrence compared to women with breast cancer alone. And so we thought one potential reason for this could be more high-risk health behaviors in this group, like substance abuse. And we know that these conditions commonly co-occur, but we don't actually understand the joint effects of these conditions well. So the objective of our study was to investigate whether having clinical diagnoses of both pre-diagnostic major depression and a substance abuse disorder significantly changes the risk of breast cancer recurrence more than we'd expect if both conditions were acting independently. So to do this, we used retrospective data from the VA healthcare system. We assembled a cohort of a little over 6,000 women who were newly diagnosed with primary invasive breast cancer between 2010 and 2019. We measured our exposures of major depression and substance abuse in this 2-year baseline period based on ICD codes, and then we looked for our outcome of breast cancer recurrence during this maximum follow-up period of 10 years. For our analytic approach, time 0 for all women was breast cancer diagnosis, and we followed them until the first of recurrence, death, or the end of our study period. And then we compared the risks of recurrence using competing risks regression, and we adjusted for these sociodemographic, clinical, and prognostic factors. And then all of our models were stratified by the type of substance abuse, so alcohol or other substances. At baseline, 26% of women had a substance abuse disorder, 29% had major depression, and 12% had both. We didn't observe many differences in baseline characteristics like age at diagnosis, their race, or cancer stage, but we did notice that there was a higher average comorbidity burden among women with either or both of these conditions compared to women with just breast cancer. In our multivariable analyses, we found that all 3 of these conditions were independent risk factors for breast cancer recurrence, and we found significant interactions. So in our analysis of alcohol abuse disorder, women with both conditions had a 65% higher risk of recurrence compared to women with neither of these conditions. And in our analysis of other substance abuse, these women had a 90% higher risk of recurrence. And in our subgroup analyses, this interaction between the 2 conditions was limited to just hormone-positive cancers. So our study highlights the importance of screening for both of these conditions, and we understand that it might not be feasible to do this for every woman, but we think that we could target certain at-risk groups of women, like veterans or those with hormone-positive cancer. Again, both of these conditions were independent risk factors for breast cancer recurrence, and this risk was even higher for women with both conditions. Our ongoing research will look at the etiology of our findings, especially across varying levels of depression, and we want to see if these newly defined risk groups could benefit from closer monitoring and more targeted treatment options. Thank you so much.
Thank you. Okay, thank you. Next presenting is Dr. Freeman from University of Chicago. A poster titled Associations Between Virtual Care Access and Psychological and Mental Health Conditions Among Adults with Breast Cancer in the U.S., a population-based analysis. Thank you.
Thank you, SABCS RIC committees, and I appreciate the opportunity to present our study. Association between virtual care access and the psychological and mental health symptoms in the U.S. breast cancer survivors, a population-based studies. I have no financial relationship to disclose. technology. Just a little background. Breast cancer survivors and then patients usually experience a lot of psychological and mental health challenges. So I think telemedicine really can facilitate access to those care and services. But also breast cancer survivors may particularly may benefits from telemedicine or virtual care visits. So however, it's not really a lot of studies are looking into that, the actual relationship between some of the psychological mental health symptoms with virtual care access. So our goal was really to explore this association between a virtual care access and psychological distress, anxiety disorder, or depression among breast cancer survivors in the US. In terms of methods, our study cohort was a population-based sample of US adults who ever had a diagnosis, a breast cancer diagnosis from the 2021 National Health Interview Survey. So in terms of telemedicine use, was defined as having had a virtual medical visit with a provider in the past 12 months. And intense psychological distress was measured in the past 30 days, really measured using the 6-item CARES scale, and then really dichotomized based on the cutoff score of 13. And then the total score is 24. And ever having had anxiety disorder or ever having a depressive symptom was per self-reported as yes or no. In terms of data analysis, we calculated weighted proportions and then compare using RAS-CRK chi-square tests. And then we also feed separate multivariable logistic regression really to calculate adjusted odds ratio and 95% confidence interval. And all analysis account for survey weights. All right, so the figure shows the weighted proportions of the virtual care access by psychological distress, anxiety, and depression. So, for example, let's look at for patients who experience serious psychological distress, 76.5% reported having used telemedicine versus 48.5% among those who did not experience serious psychological distress. And among those patients who ever had a depression, so 63.9% reported telemedicine use versus only 46.6% among those who did not have a depression. And then those with an anxiety disorder reported a high percentage, 60.4% versus 48.1% compared to those who did not have an anxiety disorder. And then after adjusting for some potential confounders, and if we look at 3 models differently, so for those patients who had serious psychological distress, so they have a more than 3 times likelihood of telemedicine use compared to those who did not have a serious psychological distress. And then for those who ever had a depressive symptom, so they do have twice as likely than those who did not have a depressive symptom to use telemedicine. So, but for in terms of a patient who ever had anxiety disorder, so we do not see a significant difference, but we do observe a greater odds of telemedicine use in this case. So some discussion, conclusion, also some results too, that overall, so we do see 1 in 5 breast cancer survivors ever have depression. And then about more than 1 in 6 survivors had anxiety disorder. And a bit more than 3% reported serious psychological distress in the past 30 days. And about half of breast survivors reported having had a virtual visit with a provider in the past 12 months. So just going to conclude that, so our findings really suggest telemedicine may be a very viable tool for improving care and services, particularly for those who experience psychological mental health symptoms. So it is really warrant ensuring equitable virtual care access and then also adequately address some of the mental health care and unmet needs in this population. Thank you.
Thank you. Next presentation we will have by Dr. Don Hirschman from Columbia University in New York. This is titled Sociodemographic Risk Factors and Prediction of Aromatase Inhibitor Non-Adherence in Women with Breast Cancer Enrolled in the SWOG S1105.
So I want to thank the organizers for the opportunity to present our results here. S1105 was a randomized trial of text messaging to reduce early discontinuation, improve adherence to aromatase inhibitors. It was a trial that looked at women that had recently started, and it was a study where the outcome was time to first event of somebody presenting with a urine that did not show that they had been taking their aromatase inhibitors as the definition of non-adherence. So we took that cohort and we analyzed baseline sociodemographic characteristics and financial factors that might be associated with non-adherence to create a composite risk score. So in addition to factors such as race, ethnicity, age, education, income, and insurance, we also looked at socioeconomic deprivation as defined by the Area Deprivation Index, as well as urban and rural residency using residential zip codes. So these are our results. And we looked at, to build a model, we looked at anything that had a significance of 0.1 to include in a model. So we looked at a variety of different factors to include age, race, ethnicity, education, income, insurance, out-of-pocket costs, as I said before, area of residence, and area-level socioeconomic deprivation. And you can see that the factors that were most associated were age, education, out-of-pocket costs, and rural location. When you take these and you create a model, it's important to note that the vast majority of these factors, even if not significant, are associated with time to non-adherence. If you look at just those 4 characteristics that met our upfront criteria, having 2 of those characteristics was associated with a 60% increase in non-adherence. But if you look at any of those factors, many of which are clustered together in populations, you can see having 5 or more of these characteristics is associated with a 2-fold increased risk of non-adherence. So in conclusion, a composite model comprising a combination of sociodemographic risk factors can identify patients on aromatase inhibitors that are at much greater risk of long-term non-adherence or early discontinuation of their therapy. And it's important to note that in addition to mitigating side effects, targeted interventions to improve adherence really should be focused also on structural barriers. And one of the challenges with interventions focused on adherence is selecting patient populations that are appropriate for the studies. Most clinical trials in this area have not been successful, mostly because they take a wide swath of patients on treatment and an intervention that's not necessarily geared towards them. So we need to personalize our approach and to improve adherence to patients at highest risk for both structural as well as physical barriers to continuing their medications.
Thank you. Next presentation, Dr. Fukima Chino from Memorial Sloan Kettering Cancer Center, presenting poster on patient-reported benefit of resources designed to assist with the financial toxicity of breast cancer.
Thank you so much for the opportunity to present our work. I want to thank the selection committee here in San Antonio, but also the community, the breast cancer community at breastcancer.org, and the patients who actually took this survey to provide this information. As you know, patient-centered research should always be rooted in the patient voice, so we're very grateful. What we know is that breast cancer as a diagnosis can cause a lot of financial distress and harm to our patients. And it can decrease their disease outcomes as well as their personal outcomes. And we know that specifically tailored interventions are really necessary to make sure that we're allowing everyone to get the very best treatment and the best outcome. in this idea that not one size fits all for financial toxicity and the financial burdens of cancer treatment, we did design a tailored survey to figure out how specifically financial burdens were affecting patients with breast cancer, but also what specific interventions or education initiatives could help them the most. The survey was done last year over a 2-month period via the breastcancer.org community and enrolled adult patients in the U.S. With a recent breast cancer diagnosis within 10 years. And we were able to survey almost 1,500 patients with breast cancer. This was, in general, a fairly young cohort with a median age of 46. It was a median time of 2 years since diagnosis, so again, sort of recent diagnosis for these patients. So in general, when we think about kind of high needs, it's more recently diagnosed or younger patients. And most of the patients were on active treatment, and 11% had metastatic disease. This cohort was fairly diverse. 60% were white, but 27% were Hispanic, 8% Black. And one of kind of the salient points of our research on financial toxicity is just that it's quite common in this population. So almost half, 47%, had either significant or catastrophic financial burden related to their breast cancer diagnosis, and that these burdens were worse in the patient population that had metastatic disease. When we asked specifically what benefit financial resources had for the patients, we asked a number of different questions. Essentially, did you use patient financial assistance programs? Did you use grant programs? Did you use the resources within your facility? A number of different questions. What we can see based on the responses is that there's a wide variety of how much benefit that our patients got, and most of the responses are kind of in the middle. So it's not neutral per se, but it's just between not very much help and a lot of help. It was sort of like it helped a little bit, it helped some, okay? But what we also found is that there were differences along either disease type, metastatic versus non-metastatic, or between the cohorts of white, Black, Hispanic, Latinx, Latini, or other patients, which include Asian patients. So this idea, again, that not all cancer treatments are the same, we need to potentially tailor our interventions for what's going to benefit people the most. That's really what I'm trying to highlight with these slides. The differences are marked in the red as the significant differences. When we asked patients what could actually benefit them, so something that maybe didn't already exist that could potentially help them, I see that do I get more time?
That did seem, yeah.
I'm going to go on for a long time now, sorry.
The clock is reset.
When we asked people what education could actually help them, would be most useful for them. We found, again, a range of responses. These are ranked choices, meaning that you were able to rank, your top choice. And so I'm showing you the number one choices. But things like, for example, a list of grants that someone could apply to, there was variable usefulness of that based on, the type of person, your background, your race, ethnicity. And so I think, again, trying to highlight that, this concept of tailored interventions should really be based on the patient need and that individual patient assessment. In conclusion, we found that when we think about the benefit of the financial assistance that's available and was used, those things that provide actual direct assistance, so grant programs, reduced cost medications, et cetera, were the ones who were rated the most highly. So again, if you have a financial need, actually meeting that financial need helps. But that also, things like a grant list, a list of questions, they could potentially be helpful education resources that could be a low-cost education for our patients, but that there really were significant differences in the race, ethnicity, and disease status in terms of the benefit of these interventions. When we think about financial toxicity as being a pervasive problem in the breast cancer community, where almost half of the patients had either significant or catastrophic burden, we really need to go to the next step, which is designing patient-centered, patient-facing interventions to make improvements. Thank you so much for your time.
Thank you so much. Dr. Conley from Georgetown University, thank you very much. She will be our discussant.
Thank
Thank you, and I will try to keep it speedy because I'm sure we all have places to go and things to see today. But I want to thank you for the introduction and to thank the organizers for the opportunity to discuss what I think are some pretty exciting presentations. And I'm going to start today with this graphic from Cancer Care Ontario, which I really love because it specifically highlights the role of primary care and supportive care in the cancer care trajectory. And as you can see, supportive care spans diagnosis, treatment, recovery, and end of life. And I think the 4 presentations today really highlight gaps in supportive care post-treatment, what we might call survivorship, at least survivorship according to the NCI definition, which is that a person is a survivor from the time of cancer diagnosis. And I think these 4 presentations highlight gaps that we not only need to mind, but also fill. And so I'm going to just really briefly recap the 4 presentations that we just heard, not in the order that we heard them actually, but in the order of the data that come closest to treatment. And so to start, Dr. Chino shared with us that she observed really high rates of financial burden in her population in those respondents to that survey. I think it really clearly indicates a need for interventions. I think that's the message we probably all took away. But when it came to intervention preferences, those preferences differed by sociodemographic and clinical characteristics, right? Again, not to beat a dead horse, but to highlight that one size really doesn't fit all when it comes to those financial burden interventions. Dr. Hirschman looked a little bit more directly at predictors of adherence. Financial burden might affect adherence, but Dr. Hirschman's study looked more specifically at predictors of aromatase inhibitor adherence following breast cancer diagnosis, and identified both patient-level factors and area-level factors that were associated with adherence over a 3-year period. I think these data really highlight the things that could be going on in patients' lives outside of just breast cancer that might impact their ability to take medications in the longer term. And I think importantly, they identify people who might benefit from additional support in taking aromatase inhibitors. Again, coming back to that theme of perhaps maybe not one size fits all. Freeman and colleagues were looking at rates of depression and anxiety and looking at the relation. Sorry, let me just back up. Freeman et al. Were looking at use of telemedicine among breast cancer patients. I think that's an issue that's on a lot of our minds after the COVID-19 pandemic. I guess coming back to my initial point was that there were relatively high rates of depression and anxiety in this sample. I think perhaps unsurprisingly observed that patients who were white and privately insured were more likely to have reported use of telemedicine, but that patients with depression, anxiety, and high rates of psychological distress were also more likely to have used a telemedicine visit in the last couple of years. I actually was pretty surprised by these results, I'm going to be honest, but I think they really underscore the need for considering access to telemedicine, and particularly access to mental health services via telemedicine. In one of the sessions yesterday, an attendee really highlighted the fact that we need to be thinking about access and that we need to make sure that technological advances don't increase health disparities. And I think that's also something that's underscored in this presentation, is that we need to be making sure that we're considering access and that we can reach non-white and publicly insured populations in addition to other populations. And then finally, Aboumrad and Viswanathan looked at data from veterans who were being treated in the Veterans Administration, looking at the impact of major depressive disorder, substance use disorder, and risk for breast cancer recurrence. I think the results were pretty powerful and pretty clear that both major depressive disorder and substance use disorder increased risk for breast cancer recurrence. But I also want to highlight that the rates of major depressive disorder and substance use disorder were pretty high in this population. I think in clinical practice, we do a pretty good job of screening for current psychological symptoms, current anxiety and depression. But this study really highlights to me that we also need to be screening for folks' mental health histories in addition, given some of the impacts that this might have. And we need to be thinking again about access to mental health services as a part of cancer care. So all of these presentations identified gaps in supportive care in the context of cancer survivorship, but I love an intervention. I'm a psychologist, I love an intervention, and so I was also really pleased to see that all 4 presentations also highlighted potential intervention strategies to address or fill these gaps. And so these are just some quotes that I pulled from the abstracts that highlight some of the ways in which we might be able to close these gaps in supportive care. And I think what really jumps out to me is that each of these abstracts highlights multi-level factors. And I think if there's one thing to take away from these 4 presentations together in context, it's that multi-level problems require multi-level solutions. This is not an exhaustive list, but these are just some of the factors that were identified in these 4 abstracts as being related to some of these gaps in care and some of the proposed solutions. And I think what's really clear to me is that if we really want to close these gaps in supportive care, we need to think about factors at the patient level, the organizational level, and the environment level. And so I'd like to close with just a couple of questions for both our panelists and for the group here. Now that we've identified some of these gaps and we've proposed some solutions, what's next? So we've talked a little bit about some people who might be at greater need for support. How do we identify those folks? How do we incorporate screening for patients who are at risk? Perhaps those folks who have a history of substance use disorder or major depressive disorder. How do we do that in the course of routine clinical practice? I know that you're all very busy already, so how do we work this in? We've talked a little bit about tailored interventions not being one size fits all. How do we efficiently deliver those? It's a great idea, but how do we make sure that people are getting the exact interventions that they need in a way that's tailored to their preferences and needs? Unfortunately, we always got to talk about the money, but how do we get these services paid for? What's the optimal insurance coverage or reimbursement structure for some of these supportive care services? I don't think that there's a right answer to that, but I think that's something we certainly need to consider. And then last but not least, what is the optimal timing of supportive care interventions for cancer survivors? Is this something that needs to come closer to the time of diagnosis or further out after people finish their treatments? I don't have the answers to this. I don't think there are right answers to this, but I do think that these are things that we need to consider, again, if we want to be closing these gaps in supportive care. Thank you.
Thank you. I think we have gone just a bit over time. Not sure if there is time for any questions. Okay. I think at this time, I will just ask one question, actually, if it's all right. But just curious a little bit in terms of the use of telemedicine. This is for Dr. Freeman. And wondering, was there any impact on age or other socioeconomic factors in terms of those who were able to utilize this platform?
Yes, so for the slides, because we have 4 slides, I'm included, but in our abstract and also our poster, so we do see, a difference, white patient versus white survivors versus black survivors, and white survivors did have a higher percentage. And then for those who, have uninsured but less likely to use telemedicine, and then those who also have other socioeconomic status, I'm thinking off the top of my head, but we do see some significant difference. But in terms of age, we don't see any difference. But actually, so I think older patients are more likely to use than younger patient. So I'm not advertising my paper, but we do see in our cohort in Chicago, so we do see older patient, so more likely to use also. But in our cohort, that actually the opposite, black patients are more likely to use telemedicine in our cohort, but maybe particularly because in Chicago, we're serving the south side of Chicago, we've seen a lot of black and brown patients. So, but sort of opposite of finding, but it's interesting because some of the samples are maybe different. So.
Yes, certainly reassuring, actually. So it was a good study to see. Any other questions from the audience? Microphone. Okay, thank you all.